Hello everybody. Today we are going to discuss a little complex topic in critical care, that is usage of continuous renal replacement therapy. So we have already seen where all the renal replacement therapy which was used, what the indications, the complications of it, the consequences of not using it, and what are the ways in which we implement the renal replacement therapy, be it hemodialysis or SLED or hemodiafiltration, all those things. But there is another technique called CRRT, that is continuous renal replacement therapy, which runs over a period of 24 to 48 hours, especially in hemodynamically unstable patients or patients who are prone for hemodynamical instability when there is a movement of fluid from one compartment to other compartment. So how the CRRT acts and how do you calculate the dose of CRRT, that is very important, because the usage of CRRT predominantly lies in your ICU. So this is also a common mode of renal replacement therapy for patients, especially in the West. It is the most commonly applied renal replacement therapy for patients with AKI in ICUs with hemodynamic instability. What is the advantage of it is, it gives a slow and sustained fluid removal, preventing major fluid shifts. So as we discussed before, the fluid shift is which matters, because this shift of fluid, even a very minimal amount of 200 ml which remains in the circuits, sometimes causes major drastic hemodynamic changes in a hemodynamically unstable patient. So a slow and sustained fluid removal is the principle behind CRRT. It is mostly working on principles like diffusion and convection. So what is diffusion, what is convection, we will see in the next slides. And what are the requirements of initiating a CRRT? Obviously a vascular access, then you need blood pumps for circulation, you definitely need a permeable membrane through which filtration occurs, and in addition to this, here you need various solutions which will be going in and out of the filter or the blood circuits and across the membrane, and a blood monitoring system. So indications of CRRT, everybody of us knows: uremia, acid-base imbalance, severe electrolyte but not very severe enough to cause toxicity, fluid overload, and AKI with hemodynamic instability. What are the various modalities of CRRT? It will be CAVH, like in short you know, it will be a hemofiltration, hemodialysis and hemodiafiltration. Based on your axis, whether it is the arterial axis or venous axis, we call it continuous arterial venous hemofiltration, continuous arteriovenous hemodialysis, or continuous arteriovenous hemodiafiltration. Similarly, if your entire axis is through venous system, then it is CVVHF, that is continuous veno-venous hemofiltration or veno-venous hemodialysis or veno-venous hemodiafiltration. The third one is cuff, that is slow cuff ultrafiltrate removal. That here what happens, here we only have a ultrafiltrate removal. What is it? We will see in the next slide. So there are two principles which are involving CRRT. One is diffusion, that is diffusion of the molecules from one side of the membrane to the other side of the membrane because of the concentration gradient or the diffusion gradient. The higher molecular membranes solutes move from one side to the other side. Then the other principle is convection. Convection is nothing but as the solvent moves, there is even a solute drag, that is the movement of the solvent from positively charged to the negative charge also causes the solute drag along with it.